Guests, distinguished delegates, and my fellow mates. We are honored to welcome you all to this esteemed gathering at this prestige Galaxy Hall. Welcome back to ISHCON 2024. It's an absolute pleasure to see you all here once again. As we get to the third leg of this incredible event, I hope you are energized and excited as we are for another day filled with innovations, learning, and aspirations. We have already witnessed some fantastic discussion and breakthrough ideas over the last 2 days, and today promises to be just as impactful. Whether you're a seasoned profession or passionate newcomer, there's something for everyone. The session now commences with Free Paper 6. It's a distinct honor to invite our esteemed chairperson, Dr. Rajkumar Manas, onto the dais.
So very good morning, and without wasting the time, I welcome you all in our morning session of free papers. And our first speaker is Dr. Rahul Dubey Puria. Rahul.
Hello. Good morning, everybody. Myself, Dr. Rahul Dupuria. I will be presenting my case report on obstetric brachial plexus palsy, a bug injury treated by modified quad surgery, oberlin nerve transfer, and tendon transfer. As we all know, obstetric brachial plexus palsy is a devastating complication associated with multiparous pregnancy, prolonged labor, breech and assisted or difficult deliveries. Poor recovery of neurological function in OBPP results in muscle weakness and imbalance around the shoulder. Progressive muscle balances causes bony deformity at the shoulder joint, affecting its movements and functions. We all know what is nerve transfer and neurotization. Let me quickly remind you all. Nerve transfer refers to fascicles from one nerve transferred into another nerve that supplies a muscle, and neurotization refers to placing nerve fascicles directly into a neuromuscular junction of a muscle. Indications are lack of anti-gravity biceps function between 3 to 9 months of age, or a pre-ganglionic injury or avulsion of nerve roots. Now coming out to our case report, we had a patient with complaints of inability to elevate and externally rotate right upper limb since birth, diagnosed as extended Erb's palsy, presented to our institute for further management at the age of 3 years. Patient was full-born term baby, breech presentation with normal vaginal delivery at an institution with a birth weight of 3.7 kilograms. Examination of his right upper limb revealed a shoulder abduction of 80 degree with no external rotation, no active movement present at the elbow, wrist and finger drop was present with, but flexion was present, and tightening of pec major and LD muscles were felt. There was contraction of biceps which were felt, and patient had intact sensory and vascular supply over the right upper limb. For the treatment purpose, the surgery termed as modified quad is based on the following steps. In the first step, the transfer of LD muscle to give external rotation and abduction, transfer of teres major muscle to stabilize the scapula, release of subscapularis, pec major and minor contracture, and decompression and neurolysis of axillary nerve, which is the most important step in this procedure. For this patient, we planned modified quad surgery with oberlin nerve transfer. Patient was placed in left lateral position and skin incision masked from anterior to posterior axillary fold. Incision or deepen in layer, LD and teres major muscle were isolated at their insertion and preserving their neurovascular bundle. Later dissection was done between pec major and deltoid up to coracohumeral ligament as shown in the figure. Intraoperatively, external rotation and function was achieved after division of coracohumeral ligament by anterior approach. Common tendon of LD and teres major was now fixed to a common external rotator tendon of infraspinatus and teres minor at greater tuberosity, and finally the neurolysis of axillary nerve was done. Pec major lengthening was done by Z-plasty at its insertion, and another incision at the same setting was given in the medial aspect of right arm in the biceps groove, and medial nerve fascicle was transferred to the fascicle of nerve to biceps brachii Thus, Oberlin nerve transfer performed. The arm was immobilized in an abduction splint for 4 weeks, after which the child was placed in a splint at night only for further 6 weeks. Full shoulder function was permitted after initial 4 weeks post-operative period, and physiotherapy was advised daily for at least 3 months. Follow-up was done on monthly basis, and within 6 months, patient was able to abduct the shoulder up to 160 degree. This is a video showing the patient result in post-op 15 months. You can see the shoulder abduction up to 160 degree, and elbow flexion is also present. In the second sitting, the tender transfer for wrist and finger extension was done, in which we transfer FCU to ADC, FDS middle finger to ECRB, and FDS of ring finger to APL and EPL. These were the result after, in the lower segments of picture in the right red t-shirt, the results of tender transfer was shown, is seen, and in which we can see wrist and finger extension. And after the surgery, following result was seen, in which the shoulders were abducted to 160 degree and wrist extension to 30 degree, finger extension up to 15 degrees, and there was no deficiency in pincer and pincer graft and fist grip. Coming to discussion, we all know that there is Naraka's classification of obstetric brachial plexus palsy, which divides it into 4 groups: upper ups, extended ups, total palsy with no Horner syndrome, and total palsy with Horner syndrome. In this patient, we had extended ups, that is group 2. To conclude, this case demonstrates an excellent result of restoration of abduction of shoulder joint and hand function by muscle release, nerve transfer, and tendon transfer procedures. Thank you.
Thank you, Dr. Rahul, for a very nice presentation. Any quick question for Dr. Rahul? Can I ask Dr. Rahul one question?
Yes, sir.
What was the rationale behind doing nerve transfer at the age of 3 years?
So we just hope that the patient will recover fast.
No, usually where nerve transfer is advisable not beyond 9 months or a year or maybe 15 months. We did the nerve transfer along with the muscles release at the age of 3 years.
But the age of the patient was 3 years, sir.
Yes, so nerve transfer, is it advisable to go for the nerve surgery at the age of 3 years? Because it is a birth brachial plexus palsy.
Yes, sir.
So patient has already passed the 36 month of age. Okay, thank you. Thank you, Dr. Rahul.
Thank you, sir.
So may I invite our next speaker, Dr. Ajay K.S.
Good morning all. So my topic on how to harvest sural and saphenous nerve from a single incision. So the commonly used nerve grafts are the LABC, MABC, or superficial sensory branch of radial nerve, dorsal cutaneous branch of ulnar nerve. So these give an unsightly scar in the forearm. So in pan plexus injuries, especially when we use the contralateral C7, we need more grafts for reconstruction. So what an ideal graft should be? Nerves with less diameter are good contour as they get early vascularization from the wound bed. And coming to saphenous nerve, it's a delicate nerve which descends along the saphenous vein, a branch of femoral nerve, which supplies the medial part of knee, leg, and foot. This is the anatomy slide just showing the course of saphenous nerve. So why a single incision? We can avoid 2 incisions on the forearm. And saphenous nerve, as I said earlier, it's a very thin nerve, can be taken from the same limb where we are harvesting the sural nerve. So I'm just going to the videos. So this is how I mark the incision. So first step is taking the sural nerve. So sural nerve is identified and looped. After that, you we get 12 to 14 centimeters of sural nerve. After that, the medial skin flap, where the cat's paw is put, that is elevated just above the muscle, deep to deep fascia. You can see the perforator coming to that skin flap. So we are going under the deep fascia. As we go, I'm not sure whether you are able to make out that tiny bluish tinge, which is the course of saphenous vein. So the nerve lies just adjacent to it. So here I have opened the deep fascia. You can see above the lies the saphenous vein, and just below that saphenous nerve. So I'm opening the deep fascia again for getting more length of the saphenous nerve. So this is after complete opening the deep fascia, we can get 6 to 8 centimeters of saphenous nerve. This is just a saphenous vein and saphenous nerve looped in this picture. This picture shows both sural and saphenous nerve harvested. So the cable graphs you can get from both limbs, you can get 6 to 8 centimeters of saphenous nerve. This picture shows the contralateral C7, which has been tunneled retroesophagally to the injured side and reconstructed with the cable graphs. So conclusion, by taking saphenous nerve also in your armamentarium, you get more number of cables. You can avoid a forearm incision, and it's a very thin graft, so early revascularization. And we have done this in more than 30 cases. Our longest follow-up is 7 years old. So we have evaluated for any sensory morbidity happening in the donor limb. Till now we haven't experienced. The only problem we have experienced is tissue dehiscence, the wound dehiscence in 2 or 3 cases. But it was managed with dressings and it healed completely. No children have any signs of any trophic changes like neuropathy picture in the donor limbs. So I'm inviting you everyone for the next BrachialCon, which is happening in Kerala next year. Thank you.
Thank you, Dr. Ajay. Any question for Dr. Ajay? It was a very nice video presentation, bloodless film. Did you prone the patient for harvesting these 2 grafts?
No,
or do it?
no, sir. No, sir. There's simultaneous approach. The other surgeon will be exploring the plexus and whatever.
In supine position only?
Yeah, in supine only. You can do it. You can do it.
Thank you, thank you. So our next speaker is Dr. Swagata.
Good morning, everyone. I will be presenting my study on evaluation of elbow function following modified cord procedure in bulb brachial plexus injury. So, bulb brachial plexus are low injury trauma and that occur during natural delivery due to excessive traction. The incidence is said to be, it ranges from 0.5 to 4, but these are institutional data. The incidence is much higher. And however, 90% of them will recover, but residual shoulder elbow deformity are not uncommon. So primary surgical treatment is brachial plexus exploration, nerve reconstruction using nerve graft and distal nerve transfer. But presenting late or partial or no recovery following nerve transfer will need other salvage surgeries, mainly soft tissue transfer for increasing the shoulder function because of poor abduction and external rotation. So modified cord procedure consists of these 4 surgeries. 4 procedures, the contracted pectoralis major that I will be explaining subsequently in the operative steps. And so why this surgery and why elbow? So out of modified cord surgery, triangular till and derotation osteotomy are the surgeries that can be done for increasing shoulder abduction in these patients. But no studies they are definitely mentioning what happens to the elbow following this surgery. And so the research question comes, what is the indirect effect of modified cord surgery in elbow function? So in my methodology, study was approved by ethics committee attempts and 25 children were included for a period of 4 years. And this is the inclusion criteria. Children aged greater than 3 years, limited active abduction against gravity with limited external rotation and presence of co-contraction along across the shoulder joint and with partial recovered elbow. However, clinically and radiologically cranial incongruency with patient with this were excluded. So first of all, incision is marked in anterior for patient in supine position, and pectoralis major is identified, it is released and abduction is checked. If further restriction is there, we will release the pectoralis minor muscle also and the fascia overlying it. Then we'll go to the posterior incision and we'll identify teres major and latissimus dorsi, release it near the conjoint tendon, and then we'll dissect the quadrangular space, identify the axillary nerve and also release it. Sometimes there is a thick band of triceps muscle compressing over the nerve, so we have to release that also. And then we'll transfer the latissimus dorsi, teres minor to teres major and latissimus dorsi to teres minor. So demography data was evaluated, followed by elbow function, shoulder abduction, external rotation was measured along with modified Mallet score. And statistical analysis was performed using R software, and Wisconsin signed rank test was applied for paired data and Manivati U test was applied for unpaired data. So this was my performer. And hand to neck and hand to mouth function was, I have also aggregated these two functions to evaluate the elbow functional score. So in my result, elbow flexion and range of motion, shoulder abduction, aggregate Mallet score and aggregated hand to mouth and hand to neck force all are significant for 25 patients. And this graph shows the significant increase in elbow function in these 7 patients, significant in the sense that initially the elbow flexion was less than 90 degree, but later on it has increased to almost 130 to 150 degrees. Here the thing to notice is that the blue line and the gray line, blue line is the elbow function and gray line are shoulder abduction. They are not collinear, they are different before the surgery. But after the surgery, both has increased, shoulder and elbow function. There is a top line, but they have become collinear. So this shows that the elbow function increases along with the shoulder function. So is a video, elbow flexion that is limited, but after the surgery, he can perform hand to mouth and hand to neck. This child, left side work and he can perform hand to mouth and hand to mouth function. This child has left side injury, difficult to perform initially, but after the surgery he can perform it easily. So different studies have shown that shoulder function increases, but no one has evaluated the elbow function. In my study, it shows that the elbow function increases following shoulder abduction. So I'll conclude that though mod cord surgery increases the shoulder function, secondarily the elbow function also increases along with that. Thank you.
Yes, please.
This presentation, a couple of things is, one is shoulder deformity. The main deformity is internal rotation. So are you releasing the subscap?
Sir, no sir, mostly we don't release the subscapularis. Without releasing the subscapulary, our rationale is that we do not want to limit the midline function of the child. So we restrict subscapularis release, sir.
Yeah, because many of these kids have good abduction. Anyway, I mean, let's not go into, we can talk about it later. The second question is, why insert into the teres minor and not the supraspinatus, and which is the standard technique, right?
Sir, mod cord was described by transferring to teres minor only, so we followed this surgical procedure, sir.
Thank you, Dr. Sagata. We are running short of time, so I invite our next speaker, Dr. Amita Hiramat. Not there. So next speaker is Dr. Bimalendu Brajesh.
Thank you, Chairperson. Very good morning to all of you. So my topic for today is long-term, and by long-term I mean more than 4 years, outcome assessment of hand function after primary reconstruction of total birth palsy patient, where only a single nerve root was available. Why we needed to analyze this patient is because the prevalence of birth brachial plexus palsy is 1.3 to 3 in 1000 live birth, but only 16% of these will fall into Narakas grade 3 and 4, which is the most severe and have the worst prognosis, and also have the longest timeline to recovery. So it is good to analyze this patient to have an idea and better counseling of the patient, and you also have to convince yourself whether what you are doing is going to give some outcome or not. So aim was to do a retrospective evaluation. Total birth palsy patients were selected, single ipsilateral nerve root based reconstruction patients were selected, and timeline and grade of recovery of hand function was analyzed. The MRI studies were suggestive of avulsion injury of C7, 8 and T1 in all these patients, and patients who had a single usable nerve root on intraoperative exploration were selected. Minimum follow-up period was 4 years, and for analysis of hand function we used the Gilbert-Raimondi hand score. The usability of nerve was purely made on clinical basis, and the cut end of the nerve was evaluated under microscope. We did not do any SCP or nerve biopsy to analyze the usability of the nerve. The single available nerve root was used to neurotize the lower trunk and along with it a suprascapular or musculocutaneous nerve with an intervening nerve graft, and the other donor nerve, that is the spinal accessory nerve, was used to neurotize the musculocutaneous or the suprascapular nerve, either ways. As we said, there are multiple assessment scores. We use the modified Gilbert-Raimondi because this, there are certain activities which is easier to place the patient into, various staging staging. So the movements can be easily picked up and patient can be graded accordingly. So a total of 12 patients of birth palsy had, of them 8 patients had got avulsion of C8T1 on MRI, and only 62%, that is 5 out of 8 patients, had a usable nerve root. Mean age at surgery was 3.6 months, and this was the demographic chart of the patients. So Raimondi score came out to be more than 4 in almost 80% of the cases. Only one patient had Raimondi score of less than of 3. We looked at the literature and we found out there is quite a variation in the outcome reported. So while Malley et al. Notes that more than 3 of Raimondi score is noted only on 40% of cases, Julia Tersis says that it is more than 4 in 100% of the cases. So we straight away go to our cases. We see that this is a 3-month-old child who had a right complete birth palsy, and the intraoperative findings, this is, you can see right side it's completely paralyzed, and this was the intraoperative finding where the upper trunk, this is the middle trunk, the lower trunk, and this is the C5 nerve root, which was the only available nerve root. So what we did, we used this C5 to neuritize the lower trunk and the musculocutaneous nerve, which is shown in the photograph, and this was the finger movement at 2 years. So you have to actually stimulate the child to initiate the movement. So this was a finger flexion movement, and at the extension, finger extension could be noticed at 4 years. The radial digits were more prominent, wrist extension was there, and things that did not improve even by 8 years were the external rotation part. Another case, 3-month-old child who had again left-sided complete palsy. So after surgery, 1.5 years, this was the finger flexion. And after 4 years, you can notice the good amount of recovery of shoulder abduction, the elbow flexion, though there is internal rotation contracture. The finger flexion is of grade 3 plus, where she is able to hold some object and raise it against gravity. And after 7 years, you can notice the wrist extension. The finger extension is lagging behind and elbow extension. So you remember, we have not done anything for the extension of the wrist or the fingers, wrist or the elbows, but majority of the patient recover the wrist and elbow extension. Another case, similar type of reconstruction was done. Finger flexion at 2 years, recovery at 4 years, good elbow flexion, wrist flexion, elbow extension. So to summarize, a satisfactory functional hand can be achieved, and it always tests the patient of the surgeon, parents and the child. Emotional and psychological cooperation of the patient is very important, and extension of elbow is restored in most of the patient without specifically addressing that. Finger and wrist extension take the longest time to recover, and secondary surgeries can be useful in improvising the functional outcome of these patients. Thank you very much.
Thank you, Dr. Vimlendu. Any quick question for him?
That was very nice. But how do you explain these additional things? See, for example, in some of the cases you showed that the middle trunk is completely not there at all. My child's sort of recovering elbow extensions, and in one of the patients you showed the shoulders going up right there. And this is impossible in a spinal accessory to suprascapular nerve transfer. The maximum we get is about 30-40 degrees of abduction. So how do you explain this, especially when you have seen intraoperatively all your findings?
That is what also surprises me, and probably one explanation can be that because there are a lot of interconnections between the nerves, probably because these all patients are within 3 months of age, and probably that can be the reason the interconnection are still, a dynamic stage where they can, neurotize structures which are not intended to, and that is probably the reason why there is co-contraction and all those things when you don't do any surgery for those patients. A spontaneous recovery may also be explained by this.
It happens to most of us. You sort of buy one, you get one free. Is that correct? It's just that you...
That was very interesting finding. But the extension, because nothing was done for the extension of the wrist and elbow.
Yeah, if I can add a point to Dr. Srinivasan and continue with that, there are many units around the world who don't do any nerve surgery for obstetric plexus. It's controversial, and they just deal with the after effects after a couple of years and do the salvage procedures. So we don't know why they recover so well in spite of having a nerve injury, but a lot of units around the world don't do any nerve surgery for OBVP. It's controversial, just an addition. Yeah.
But doctor, one point I would like to make over here, that in the first case which I showed, they were all explored brachial plexus, and we had seen there was an avulsion injury. So they were all separated. So there is no chance of spontaneous recovery in these patients. Still there was this recovery which was noted.
Thank you, Dr. Vimlendu. We can discuss this during the tea time. The next speaker is Dr. Krishna Priya Das. Is he here? No. So, if he is not there, may I invite Dr. Subrat Jena sir to speak on this topic.
Good morning, Chairperson, and early morning risers. May I wish you a very good day ahead. Decision making in upper extremity implantation has been changing, has been evolving. So there was a time when 25 years back, I got this young man, left hand amputated by a very sharp, heavy knife. I went ahead single-handedly with a technician and did it and got very good results. But not always so. You get less and less knife or assault injuries. These days you get more and more cross avulsion injuries leading to amputations in industrial setup and in road traffic accidents. So it's often stated that the worst results of successful reimplantation is better than the best prosthesis available. I don't think everybody will agree to this. You are seeing very good prosthesis available in the upper limb, and therefore, if it is a very deformed and the functions of the hand is not very acceptable, the patient may also come back and say that this was not what he expected from the surgery. So this is again a simple amputation. You can predict the return of function. But when it comes to something like this, you have a devastating injury. You know, the bone and everything is cut at different levels. How much of the limb and the function can be salvaged is a matter of question. So this was 5 years back, early morning, the patient was taken into the theatre, and you see 5 days post of result on your right, and it would be kind of surprising for a young novice surgeon that yes, even this kind of a hand can be replanted. So there are some cases will be in the gray zone where I have through this paper tried to achieve some clarity for the benefit of young surgeons and outline what are the procedures that should be done in a very major proximal implantation. So you scheme a time apart, you should have a very readily available team to do this kind of surgery. You need an orthopedic surgeon, you need a mature and experienced anesthetist to see you through the changes that the hypoxia must have produced with a lot of muscle in the distal part. So one good thing to is to perfuse the amputated part with copious amount of Ringer's lactate before it is reimplanted, which sometimes brings down the intensity of perfusion syndrome. And the other thing that can save time in these circumstances is a quick external fixation. A quick external fixation and not a detailed internal fixation which the patient can always have later will help you to tide over the situation, because there are a lot of muscle mass involved. And then the temporary limb salvation, they are nothing but silicone tubes inserted into the vein and to the artery and couple of veins, which buys you time. Anastomosis of as many veins when it is a major limb implantation is essential. Primary nerve repair or grafting, whatever is need to be done, and providing a viable cover for all the repair site, because most of the time the local tissue may not be, as I said, most of them are cross avulsion injuries. So you need to cover them up with a LD flap or a pec major flap. So pediatric amputations, sometimes it is very risky to undertake reimplantations in a young child, especially in this child when the patient has a multiple level injury, but then they should be given a chance. And if you have the armamentarium and you have the assistance, then you can go ahead, again an external fixator, some pins through the radius and ulna, and an external fixator has helped us to save the arm of this child. Can I take a minute more? This child was playing with a ball when the ball got into a lift with a collapsible door. So when his hand was inside the lift started moving down. So that is how it happened. So multiple level injuries were a kind of relative contraindications. But even though the function is not very good, but we can salvage some of these patients by suitable modifications in the technique. Now this is again an amputation through arm. The hand result is typically much less than expected. However, they can be improved. It's almost like we treat them as brachial plexus injuries, right? So even though you coapt the nerves, still the return of function is not very good. So, but the hand function can always be improved by secondary surgeries, like in this patient who had a carpometacarpal joint arthrodesis and an intermetacarpal arthrodesis. The picture A shows the pre-operative position B shows the post-operative position, and C shows a functional hand. Pec major transfer is almost always essential when there is an amputation through the arm, because the biceps and brachialis muscles are crushed and get totally scarred, and they don't, they may get innervated, but they don't do well. So the other thing is in a proximal level amputation, liberal fasciotomy in the arm and forearm is almost always to be done. This is a 2-level vascular disruption in a young man.
Sir, can you conclude, sir?
Yeah, maybe 30 seconds?
Yeah.
Okay. So the 2-level injuries. So this was done successfully, and this is the patient with his function. Again, he also had a pec major transfer. So this is after the pec major transfer and rehabilitation of the hand, he is able to get back on his bike. So therefore, this is the only one case that I operated amputation to shoulder level, disarticulation to the shoulder level, and it made a huge noise that the doctor joins a severed arm. It came out in the newspaper. This was for the sake of awareness. Now, what I would like to emphasize is that proximal level amputations, especially those sustained in road traffic accidents and industrial setup, are not simple amputations. They call for a lot of care and experience to handle them, but they are doable. Thank you.
Thank you, sir. You have a very good series of the replantation, major replantation. Now invite the next speaker, Dr. Pawan Dikshit. Since we are running short of time, maybe after the things we can discuss.
Thank you, Chairperson, and good morning to all. I will be talking about dorsal carpal artery perforator flap. Defects over dorsum of hands generally require flap cover. Groin or posterior interosseous arteries are most commonly used pedicle flaps. Free tissue transfer has also been commonly done. Local option like rotation flap or O2 jet flap for small to moderate defects over dorsum of hand has also been described, but they have no defined vascular basis, and there are very little maneuverability to use these flaps. So to study the vascularity over the dorsum of hand, we performed an anatomical and clinical study. In anatomical part, the hands of fresh frozen cadavers without any previous signs of major trauma or deformities were chosen. Radial and ulnar arteries were exposed in the forearm and were cannulated. After that, an infant feeding tube has been passed to the arteries and irrigation was done with the warm water. Then the liquid latex was injected and the completion of infusion process was confirmed. Then cadaver placed in the deep freezer for 36 hours for the settling of latex. And after that, after 36 hours, the cadaver was taken out, incision were given on the dorsum of hand, and dissection under loop magnification was performed to look for the perforators. So size, length, and location of the perforator were noted. Caliber of the source vessel, distance from radial and ulnar styloids were also noted. In clinical part, the patients with defects over dorsum of hands were chosen. The patients with extensive defects or mangled hands were excluded. The location of perforator, which was suggested by the previous anatomical part, were marked, and it was confirmed using handheld Doppler. Flap size, number of perforators included in the flap, outcome and complications were recorded. So total 12 hands in 6 cadavers were used, and on dorsum of hand we found 2 perforator system. One, the perforator which was based on the metacarpal artery, which is well described in literature, and the second one is the perforators based on the dorsal carpal artery near the wrist joint. So I will be talking more about this dorsal carpal artery perforators. Dorsal carpal artery is the branch of radial artery on the dorsum of hand, which anastomose with the ulnar artery, dorsal carpal branch of the ulnar artery, making a dorsal carpal arch, and perforators arise from these arches. We found that there are 2 distinct rows were present over the wrist, and on the basis of their location, we call them as a proximal row and distal row perforators. So the proximal wrist perforators were 2 to 3 in number. Perforator sizes was approximately 1.2 mm, and the distance from radial and ulnar stelloid was roughly 4 centimeter. The distal wrist perforators were more in number, 3 to 4, but their perforator sizes were small, and the distance for radial and ulnar stelloid was 5 to 6 centimeter. In clinical part, total 5 patients were chosen, were included in the study, and 80% defects were in the right dominant hand. Trauma was the most common cause. The mean defect size was 21 centimeters square. All the patients were operated in regional blocks, and all flaps have successful outcome without any complications. This is one case in which there is a defect over the dorsum of hand. We mark the perforator as per the findings of the anatomical study. These are the intraoperative measurements of the distances from the bony landmarks and caliber. Then the flap were islanded on perforators, and it was closed in a VY fashion, and this is showing a result at 3 weeks post-operative. This is another patient which has this defect over first metacarpal head, and the flap based on perforator were used to cover this defect. So in 2020, Yu et al. Reported first time a VY advancement flap that is based on the dorsal carpal perforator. In present study, we consistently find there were 2 distinct row of perforators. So proximal perforators are larger in size, and they are closer to ulnar stelloid, and the distal perforators, which are more numerous but smaller in size and situated closer to the radial stelloid. So to conclude, the flap based on dorsal carpal artery perforators are an excellent alternative for small to medium sized defect over dorsum of hand. Thank you.
Thank you, Dr. Pawan, for very interesting flap, new innovation. Any question for Dr. Pawan? Okay, thank you, Dr. Pawan.
Can I ask him one question?
Yes, please.
In how many situations did you plan this flap and you abandoned it because you couldn't move it? Because if you have perforators coming from all sides which are perfusing this, that's great for the flap, but it's not great for the mobility, especially. So in how many situations did you plan this, but you couldn't move it and then you did something else?
No, we didn't abandon this procedure in any patient. We just used in just 5 patients now. Maybe in future we can go about and see is that possible or not.
Thank you, Dr. Pawan.
Thank you.
May I invite Dr. Hers, our next speaker.
Good morning, Chairperson and delegates. I shall be speaking upon my study on correction of radial width deformity following radial or posterior interosseous nerve palsy patients. Radial width deformity is one of the possible imbalance following any PIN palsy or injury, and also following a tendon transfer done for radial nerve or PIN palsy. However, radially deformed width often leads to fatigue and impaired grip strength. Thereby, we propose a study with an objective of correcting this radial width deformity by transferring the anconeus muscle extended by an intermuscular septum to the extensor carpi ulnaris tendon. Before we proceed, let's review the anatomy once. Anconeus is a small peniform muscle, roughly of the size of 7 by 3 centimeters square. It does not have its separate tendon, that's why it requires an periosteal extension. It's innervated by the triceps medial head motor branch. The neurovascular pedicle lies in the proximal 1/3 of anconeus, that's why the distal elevation is shaped. It has been shown to play a role in the final range of elbow extension, pronation, posterolateral stability of the elbow, and also ulnar stabilization during wrist ulnar deviation. And although the literature says that anconeus can be utilized for lateral epicondylitis or interpositional arthroplasty. Thus, if the tricep function is preserved Ankonius is spared and can be available for transfer. My study comprised of 8 patients, of which 2 were of radial nerve palsy, 2 were of PIN palsy, and 4 were of concurrent tendon transfer done for radial nerve palsy. The youngest patient was 13 years and the oldest was 72 years. The follow-up was done at an average period of 10 months, wherein we assessed for the radial deviation on wrist extension, goniometer to assess for the active ulnar deviation, any complaints of pain, elbow pain or instability, and also to check the strength of elbow extension. The surgical procedure comprised of incision along the ulnar border and identifying the muscular fascia between the ECU and FCU. This muscular fascia was then harvested along with the periosteum. The dissection was done from distal to proximal, including the distal 3 cm of Ankonius muscle. This harvested septum was transferred to ECU in a side-to-side fashion, with wrist kept in extension and 20-degree ulnar deviation. The rehabilitation comprised of extending the elbow while ulnar deviating the wrist, and the physiotherapy was given on an average for 3 to 4 months. That's an intraoperative photo showing the elevated intermuscular extension with the harvested Ankonius. The results of our study, it showed correction of the radial deviation in all the patients except for 1 patient who were treated for deformity correction at rest. Additionally, we could achieve active ulnar deviation for posterior interosseous nerve palsy patients and also those for concurrent tendon transfers. The elbow extension was maintained in all of the 8 patients, and there were no complaints of any pain or elbow instability. We all know about the standard tendon transfer described for radial nerve palsy, wherein we transfer pronator teres to ECRB, FCR or FCU is transferred to the finger extensors, and palmaris longus is given to the extensor pollicis longus. However, there is a prevalence of 30 to 70% of patients who have undergone tendon transfers to have radial wrist deviation. Subsequently, there have been several modifications in the past to correct this radial deviation, like Jones, Brand, and Ding suggested modification for ECRL and or ECRB, considering the intertendinous adhesions which are responsible for the radial deformity. Tubiana suggested transferring the ECRL tendon to the ulnar aspect of third metacarpal base. Suge and Adachi proposed FCU utilization for finger extension restoration. However, that did not correct the radial deviation. And also several people in the past have tried to reconstruct the ECU by transferring pronator teres to ECU, ECRL to ECU, brachioradialis, or even plication. To conclude, apart from the various aforementioned techniques to correct the radial deviation, but these are achieved at the cost of active radial deviation. So they can be achieved either by division of the ECRL or by creating a check vein defect on the ulnar side. Our technique, our proposed study has the advantage of a viable alternative and restoration of few degrees of ulnar deviation without impairing the radial deviation. That's my limitation, wherein the sample size was small because we had a protocol of treating nerve repair for radial and PIN palsy, and also the short period of assessment of 10 months couldn't exclude the attenuation of tendon transfer. Those are my references. Thank you.
Thank you, Dr. Hers, for very nice presentation. Any quick question? There is no question. I invite next speaker. Thank you, Dr. Hers. Dr. Srinivasam Rajappa.
Good morning, all of you, and I'll be presenting the results of surgery, which is outcomes of scalenectomy and conjoined tendon tenotomy in neurogenic thoracic outlet obstruction. Thoracic outlet obstruction seems to be like belief in God. There are people who believe that it completely exists and every patient has thoracic outlet obstruction. And the contrary belief also exists. There are people who believe that it is a myth and it is overdiagnosed. This is a paper in the Annals of Neurology by 2 prominent people. One is David Roos of the Roos test fame, and the other one is Asa Wilborn. And both of them sort of contradicting each other and then in the same page. And if you look at literature, there are multiple problems which have been described. the offending structures are multiple, starting from ribs to facial bands to so on and so forth. And the approaches to this problem have also been so many that it leads to massive confusion. There was some amount of clarity which was added by this paper, which basically said that neurogenic thoracic aortic obstruction was happening at the pectoralis minor level, or they like to call it the pectoralis minor syndrome. So, what is the basis for our approach? The basis for our approach is first believe that the problem exists, because every patient, or rather many patients who came to see us had these problems. The only problem was believing that they had this problem. And if we look at literature, this definitely is there. Of course, we reviewed that. And then why did we go and do these multiple things like scalenectomy as well as a conjoint tendon tenotomy and also removing some accessory ribs? The fear of missing a structure which was possibly the offending structure, and I don't get a chance to go back and do the decompression. So the aim of the study was, as I mentioned, to assess the outcomes of neurogenic thoracic aortic obstruction, which was treated with scalenectomy and conjoint tendon tenotomy, also excision of accessory ribs. So this was done in a tertiary care university hospital, in a hand surgery department. This was not in a vascular department. I think there's a lot of difference in perspective. The data was collected prospectively. The inclusion criteria was patients who partially met the criteria. Why I say partially met the criteria is one of the major criteria for diagnosis of TOO is scalene blocks, which we did not do in the diagnosis. Patients who underwent scalenectomy, conjoint tendon tenotomy, and removal of accessory ribs were included in the study, and we did not include patients who did not have enough data. The exclusion criteria, if there was additional venous or arterial compression, patients with peripheral neuropathy or peripheral vascular disease were excluded. If there was compression of the brachial plexus because of other problems, they were also excluded. And if patients had undergone surgery for the same reason elsewhere, they were also excluded. The referrals were from other departments, however, they were walk-in patients. History and clinical examination and documentation was done. We always got an opinion from neurology and spine surgery to make sure that there was no other problem proximally and we could be barking up the wrong tree. MRI of the cervical spine with the brachial plexus screening was done in all patients, and nerve conduction studies were also done. So a trial of non-operative treatment was given. If this did not work, they were suggested to undergo surgery. The data which was collected was patient demographics, underlying medical conditions. If they had had previous surgical history of nerve decompressions, which was there in one of our patients' occupation, and then what other treatment they had had for thoracic aortic obstruction. The most important data we collected was pain, and there was a little bit of a problem because except for the VAS, we couldn't do anything else to sort of quantify the pain. So we asked patients to draw what is a pain diagram. This is again not very new. You give these patients a picture like this and you ask them to color code various symptoms, which is burning and so neurological examination had a Tinel, all the provocative maneuvers, quick dash score, and sensory examination with monofilaments and pinch and grip strength measurements. These are the provocative maneuvers which were done. So this is a clinical example of a patient who had a similar an operation, had a left-sided cervical rib, usual exposure of the brachial plexus, a supraclavicular, and then a removal of a cervical rib, and then a conjoint tendon tenotomy. The post-operative protocol is we give them adequate analgesia, and as soon as they can do whatever they want to do, you just allow them to do it. The study period was from 2020 to 24. We had about 6 patients, 4 women and 2 men. The left side was more affected than the right side. We had 3 patients on whom there was a cervical rib. MRI was done in 5 patients only because 1 patient had a dental implant. So the nerve conduction study was normal in all the patients. So this was the pain diagram. The VAS was 9 out of 10 preoperatively, and there was a considerable amount of improvement. So this is the sum and substance of our study. There was definitely a significant improvement in the pain, but none of them were completely pain-free. The quick dash also had significantly improved. 2 patients had injury to the jugular vein, which was repaired intraoperatively. 1 patient developed intrinsic muscle weakness, but there was no sensory loss. A lot of, 4 out of the 6 patients had significant scar tenderness, especially over the anterior part of the shoulder. So, in conclusion, I'd like to say that it definitely exists, but it should be a diagnosis of exclusion. The pain is not radicular, it's more global upper limb. You can also have interscapular and supraclavicular pain. Imaging to rule out the presence of a cervical rib and other causes of nerve root compression, because one of the patients in whom we didn't succeed, there was Tarlow cyst at the level of C7T1, maybe contributing to the problem. Electrodiagnostics is most often than not normal. And I think it's a very good option for a patient who's having this problem. Thank you very much.
Thank you, Dr. Srinivasan. Any question? We have few minutes. Yes, please.
Dr. Srinivas, do you do first rib excisions in these patients or?
I don't, sir.
You don't?
The reason behind is that it was scary. I have no problems in admitting it. And there were a lot of papers which said that first rib excision was not necessary. But I have to confess that although I said there was a significant improvement in the VAS, not all of them were pain-free. The most reason for the residual pain was in the supraclavicular, suprascapular area and the part of the neck. The limb pain went off. So maybe there was some more decompression to do. Go and take the first rib off.
Thank you.
Thank you, sir. If there are no more questions, I close this session and pass the dice to the organizer. Thank you very much, everyone, for joining to us.